in UK, but it's 10 past in the night in Bangladesh. So thanks for everybody joining so late from Bangladesh, and welcome to our session about acute aortic dissection, the management strategies and the controversies. Um, my name is Saeed Sadiq. I'm one of the consultant cardiac and aortic surgeon in Sheffield Hospital, and also the lead faculty in planetary health in the cardiothoracic surgery. We have got an excellent panelist, group of panelists today, and an excellent talk by one of our rising star, Dr. Ruhina Alam. She's going to talk us about the aortic dissection management strategies. Ruhina is working as a specialty registrar in the Royal Papworth Hospital at the moment, and she will be giving us the talk today. On the panelist sections, we had Jahangir Kobir sir, unfortunately hasn't been able to join yet, and Farooq sir hopefully will be joining soon as well. The next, we have got Dr. Renata Greco. Dr. Greco is a consultant cardiac and aortic surgeon, has special interest in aortic surgery, especially complex aortic surgery. And she is actually one of my best mates in Sheffield at the moment. We've been working together for nearly 4 years now. And so she has kindly agreed to be a panelist today and will share her experience and expertise about aortic dissection management. We have got our own Dr. Shakil Farid, as we all know, the trustee of PHA and the consultant cardiac and aortic surgeon in Papworth Hospital. Shakil Bhai is actually having his dinner somewhere, I presume. So, but thank you very much for joining, Shakil Bhai. As usual, it's great having you here. Um, we have Dr. Sohail Ahmed. He's a senior consultant of and coordinator of cardiovascular and thoracic surgeon in Evercare Hospital. And we have got Dr. Arman Wadud. He is an associate professor and consultant cardiac surgeon in Department of Cardiac Surgery in Ibrahim Cardiac Hospital. We have also Dr. Prashant Kumar Chanda. He's an associate professor and senior consultant in cardiac surgery in Square Hospital. I'm sure that Dr. Prashant hopefully will join soon. And we have in our panelists Dr. Sabi Miskolsi. He's a consultant cardiac surgeon and the lead cardiac surgeon in Southampton Hospital, University Hospital Southampton. Sabi is just logging in at the moment, so hopefully once you join in, we will reintroduce him. But I will ask Ruhina now to share her presentations. So basically what we are planning to do is that Ruhina will go through the topics today, and then we have got a small announcement from Dr. Shakil about the London Core Review course that's going to happen in Bangladesh. And then I was planning to show you a couple of scans and to talk through about those cases regarding their management strategies and the decision making and some pitfalls. So Ruhina, it's all to you now. Thank you very much for giving the talk today.
Good afternoon and good evening, depending on which part of the world you're in. Thank you so much for inviting me to give this talk in this session organized by Planetary Health, and also a great many thanks to for inviting me. So aortic dissection is currently still has remained as kind of a challenge for in terms of diagnosis and management. So the first reported case of aortic dissection was from 1760. So King George II was famously known to have an aortic dissection and passed away from it. And the reason we know that is that because he was a king, there was a autopsy performed, and the autopsy showed that there was a transverse fissure in the inside of his aorta, and that's essentially is the first reported case of aortic dissection. Aortic dissection is the most frequently occurring and catastrophic manifestation of the so-called acute aortic syndromes. The others include intramural hematoma, penetrating aortic ulcer, and ruptured thoracic aortic aneurysm. Dissection of the aorta occurs when the aortic media is separated, usually by the pulsatile flow that penetrates the intimal layer of the aortic wall. This allows blood to flow between the layers of the aortic wall, forcing the layers apart, creating a false lumen parallel to the native aortic lumen. The false lumen can propagate in both directions from the tear of the intima and can affect most of its distal branches. The incidence of aortic dissection is around 0.5 to 2.95 cases per 100,000 people annually. In the UK, it's approximately 6 per 100,000 people. It's more common in men than in women, and the incidence increases with age. The total case fatality rate is estimated to be 73%, pre-hospital death up to 49%. The risk factors for dissection, all the risk factors that we have for ischemic heart disease, they are also true for aortic dissections. So those are the lifestyle and cardiovascular risk factors like hypertension, increasing age, dyslipidemia, smoking, cocaine. The other important thing to consider in the discussion of aortic dissection is congenital and connective tissue disorders like bicuspid aortic valve, Marfan syndrome, Ehlers-Danlos, Lewis-Dietz, Turner, and familial thoracic aneurysm and dissections. Vascular inflammation like Takahashi arteritis, Beckett disease, giant cell arteritis are also put people at increased risk of aortic diseases. And obviously, we all know about dissection that can happen arteriogenically during catheterization or during arterial cannulation during heart operation. Before the 1950s, much like repair of the aortic aneurysm, it was long thought impossible to correct aortic dissection surgically. Shenan et al. Described 9 different types of aortic dissection in 1934, following a review of 234 autopsy cases. In 1955, DeBakey described his emerging experience in surgical repair of aortic dissection. But notably, these were all in descending aorta, as repair of the ascending aorta was more complicated and was not yet possible. During 1959, DeBakey described 2 basic forms of aortic dissection, distinguished by whether the dissection is limited to the descending thoracic aorta or if it involved the ascending aorta. And that's how the DeBakey classification of the aortic dissection was developed. Currently, in current practice, we have the DeBakey classification and the Stanford classification. Stanford classification is quite straightforward. So if the ascending aorta is involved, that's Stanford type A. And if the ascending aorta is not involved, then it's Stanford type B. Nowadays, because of wide variety of presentation and of aortic dissection, there is a new variant that is more and more used. That's a non-A, non-B, essentially, which means that when the arch is involved, depending on which part of the arch is involved, it's either a non-A aortic dissection or a non-B aortic dissection. The other significant development in the last few years is the newer type of TEM aortic dissection classification, which kind of classifies the dissection in T type, type A, B, type A or B or non-A, non-B, entry tier, where exactly in the aorta the entry tier is and whether the patient has radiological malperfusion or clinical malperfusion. TEM classification actually adds clarity regarding the extent of the disease process and enables outcomes to be predicted initially, as we know that not all aortic dissections are the same. Type A aortic dissections can have catastrophic consequences, such as cardiac tamponade, malperfusion of coronary arteries, aortic regurgitation, and compromised blood flow to the head and neck vessel, to renal arteries, or to the iliacs. Diagnosis of aortic dissection is made by a thorough history, medical clinical examination, and imaging studies. Patients usually present with sudden onset of severe ripping, tearing, chest pain, It might be back pain if the tear is in the descending aorta, and more importantly, the site of the pain can migrate. And in a small proportion of patients, there might not be any chest pain at all. Clinical examination would reveal most of the times a hypertensive patient who might have differences in blood pressure in between the right and left side, and a radial pulse deficit. The patient might have a diastolic murmur indicating an aortic regurgitation, and they might have focal neurological deficit like limb weakness or paresthesia. In late cases, patients might present with syncope or hypertension. So who gets the imaging? If we image every patient presenting in A&E with chest pain, that's not feasible. There are some risk scores available that might help us guide in identifying patients requiring imaging, like the aortic dissection detection risk score and the aorta score. These scores are not externally validated, but they do provide some idea of how to categorize patients in terms of who went on to have a CT scan or some further imaging. In the aortic dissection detection risk score, if the patient has a high risk of having a dissection, if their score is 2 to 3, and these are in 3 categories. The score is divided into 3 categories. So the high-risk conditions like the connective tissue disorder, high-risk chest pain, and examination features. The aorta simplified score is also kind of mostly clinical items of what type of, how the patient is presenting, and a score above a 2 shows a high probability that the patient will have aortic dissection. So investigation-wise, an ECG and a chest X-ray are mostly done to exclude other causes of chest pain. But it's important to remember that an ECG showing the features of a myocardial infarction could be a presentation of an aortic dissection if the coronary osteas are involved in the dissection process. So meticulous history is quite important in these cases. A chest X-ray, the typical features of an aortic dissection is a chest X-ray is mediastinal widening and disruption of the normally distinct contour of the aortic knob, and the trachea might be displaced. A bedside transthoracic echocardiogram might identify a flap and might identify pericardial collection. As per the recent 2022 AHA guideline, a CT scan is recommended for as the initial diagnostic imaging, given its wide availability, accuracy, and speed, as well as the extent of anatomic detail it provides. Transesophageal echocardiogram and MRI are reasonable alternatives for initial diagnostic imaging, but MRI would take too long, so CT scan is currently the investigation of choice in the diagnosis of type aortic dissection. And the CT scan is an arterial contrast enhanced scan, preferably ECG gated, and a CT scan should be scrutinized to identify the location of the primary tear, proximal and distal extent of the false lumen, and radiological evidence of rupture or malperfusion. The management strategy include the initial medical therapy, transfer of the patient to an appropriate unit, and the surgical triage. As per the newer guideline, as per the 2022 AHA guideline, a patient presenting in hospital with acute aortic syndrome should have prompt antihypertensive therapy and invasive blood pressure monitoring with an arterial line in an ICU setting. The blood pressure measurement, the systolic blood pressure should be less than 120 millimeter of mercury, and heart rate should be in between 60 to 80. And it should, the patient should, hypertension management should include intravenous beta blockers, obviously except in patients with contraindication. And the patient should also be treated with pain control to help with hemodynamic management. These are important guidelines that has come out, because when we do get a referral from a peripheral unit, these advices are quite important for us to transfer to them so that the patient can have their management started at their local hospital before they come to us for their definitive management. So as per transferring the patient, so if a cardiac surgery is not immediately available, it's reasonable to transfer to a comprehensive aortic center. And more importantly, if someone has a complicated acute type aortic dissection, then it's recommended that they can be transferred to a high volume center from a low volume center. Surgery remains the standard of care for type A aortic dissection, and the surgical trial is dependent on clinical findings and imaging findings. In terms of surgical strategy, there are a few things we would need to think about before we embark upon surgery for a type aortic dissection. So what would be our cannulation strategy? What would be the cerebral protection strategy? And what would be the extent of proximal and distal repair? So cannulation strategy wise, historically, the femoral artery was used as the arterial inflow site for initiation of cardiopulmonary bypass. During repair of aortic dissection, it made sense because these are easily accessible and can generally achieve adequate true lumen flow. However, the safety of the femoral artery cannulation has been questioned recently due to the potential risk of retrograde embolization of atherosclerotic plaques to the brachiocephalic branches, as well as the risk of malperfusion related to flow reversal in the distal aorta. Even then, femoral artery remains the most common cannulation site. The alternative cannulation sites are right axillary, innominate, or right common carotid arteries. These are being more and more adopted in part because they provide the added benefit of seamless initiation of selective cerebral perfusion. Central cannulation can be rapidly established by ultrasound-guided cannulation in the ascending aorta over a guide wire. It is particularly useful when the dissection process extends into the brachiocephalic branches, or a rescue measure if malperfusion develops after a cardiopulmonary bypass. Also, this is quite important if the patient is quite unstable and we can't do an axillary cannulation and the patient needs to crash on cardiopulmonary bypass. In terms of recommendations, so the recommendation from the consensus statement from American Thoracic Surgical Association is the right axillary cannulation is reasonable in stable patient. However, direct cannulation with image guidance is reasonable. Then we come and also circulatory. So the next point is what would be the cerebral protection strategy. So hypothermic circulatory arrest is used during repair to facilitate open distal anastomosis, and hypothermic circulatory arrest could be in between 14 degrees, which is severe hypothermia, to as high as 34 degrees. In the earliest instances, the pioneers of aortic arch surgery, they use profound hypothermic circulatory arrest, which is like 14 degrees, a strategy that sometimes is still being used, which is deep hypothermic circulatory arrest, which is 20 degrees. But nowadays, with the inception of antegrade cerebral perfusion, there's a paradigm shift towards the use of warmer temperature during aortic dissection operation. So in terms of what would be the extent of the proximal repair, if the aortic valve, if the coronary osteas are not involved, then it is possible to resuspend the aortic valve and do and essentially do an ascending aorta replacement. However, if the dissection has gone into the root and kind of involving the into the root into the ostia, then obviously they would need an aortic root replacement. And in terms of ascending aorta replacement, the recommendation from the consensus statement from ATS is that the ascending aorta should be completely resected, and the tear should be identified by open distal and fine suture, pericardial neomedia, and sometimes folded adventitial collar. In terms of how much of the arch is involved, this can involve a hemiarch replacement. In terms of recommendation, so aortic root replacement is recommended in acute type aortic dissection if there's root aneurysm or primary tear in the root. And also, even without that, the root replacement is reasonable if the patient has Marfan syndrome and other hereditary thoracic aneurysms. Essentially, if they're at a higher risk, even if their root is not involved, the recommendation is root should be replaced in this group of patients. And circulatory arrest with open distal anastomosis is the recommended way of doing the distal anastomosis in these group of patients. And the extent of the resection should include the entire ascending aorta and primary entry tear. In terms of how much would be the extent of the distal repair, depending on whether or not the arch is involved. If the arch is involved, then there could be conventional total arch replacement or the hybrid technique of frozen elephant trunk. And essentially, that's the recommendation is if the arch would need to be intervened on if there's a primary entry tear in the arch and there's an arch aneurysm. So to summarize, so essentially in the surgical intervention of aortic aneurysm, the main goal is to give the flow back to the true lumen. So make sure the blood flow is in the aorta, and however that can be achieved. So this is the summary of all the recommendation of what would be the strategy for repair and what would be the strategy for perfusion. And it just describes what I've just already said. So type A dissection, partially dissected root, no leaflet pathology, valve resuspension. And in terms of extensive destruction of the root or root aneurysm, then mechanical or biological valve conduit. And in terms of open distal anastomosis for distal repair, and if there is a significant arch aneurysm or tear in the arch, then more extensive operation. So in terms of how the patient would be set up, so these operations are big operations and need a good team of surgeons, anesthetists, perfusionists, and the scrub team, because there's a lot of things going on. So from the anesthetic consideration, Mr. Farid will know that this is how they set up in Papworth. So this is for all dissection patients. So they will all have 3 arterial monitoring, multiple large bore venous, so rapid transfusion, urinary catheter, cerebral protection, and in terms of perfusion, so bifurcated aortic line for central and for anterior cerebral perfusion, and separate warm and cold bath. So there's a lot of things happening, and everyone knows what is expected from them. So it's essentially a team approach of dealing with this patient in theater. A separate consideration in type aortic dissection, but important, is malperfusion syndrome, because it is the single most important poor prognostic factor, and it's the second major cause of death after ruptured aorta. And it does happen almost in a quarter of the patient with type aortic dissection, and it is a major surgical challenge. So the newer guidelines have come up with some kind of a streamlined approach of how to manage this patient. So if type aortic dissection presenting with mesenteric and renal perfusion, the recommendation is that an endovascular fenestration or an intervention should be done before they go in for their aortic surgery. In terms of stroke, so malperfusion to the brain, the recommendation is we should just do the surgery and resume supply to the brain. In lower extremity ischemia, so the idea is, okay, we try to give blood back to to the leg to see whether that improves. If not, then obviously that would need a target vessel stenting. And this is the recommendations. Thank you.
Oh, Rina, that was really, really nice. Thank you very much. It was basically a huge topic you have sort of summarized in a very, very nice and just way. I'm really pleased. You've done a fantastic job and a very hard work. Before I go into any details, I just like to introduce two of my panelists because Sabi has just joined now. Dr. Sabi Miskolci is a consultant cardiac surgeon and a lead surgeon in University Hospital Southampton, and basically one of my trainer in my early period when I was young, and one of my very good friend. And thank you very much for joining, Sabi, today. Uh, Thanks. And our the most important panelist, which I forgot to mention, I'm really sorry for the Dr. Sadia Islam. She is a vascular cardiothoracic radiology specialist. Also, she used to work in Papworth Hospital as a consultant radiologist. Now is a junior faculty in Massachusetts General Hospital in Boston, and she's also the faculty lead in the planetary health. Sadia, thank you very much for joining. Please forgive me that I did not introduce at the beginning. I missed somehow. You're like basically it's just so close that I didn't actually just completely forgot.
I think
Uh,
I was
but
introduced before everyone joined, so probably that's the reason.
yeah,
Yeah.
yeah, probably, yeah. Let's put it like that. So before we go into any further discussion about this talk from our this fantastic talk to our panelist, I'd just like to ask Dr. Shakil Farid, because he wanted to give us an announcement for the upcoming London Code Review course that is going to take place in Bangladesh. Uh, Shakil bhai, are you okay to do it now?
Yeah. Thank you, Asif. Ruhina, do you have the PDF file that I gave to you in the morning?
Yes, I do. Let me just share this.
Can you please put that up? Yeah.
Yes, yeah.
No, thank you, Ruhina. That was a brilliant presentation. You have really eloquently given a summary of the management of type A aortic dissection. I'm sure there will be fantastic discussion regarding this afterwards, interactive discussion. I just wanted to make an announcement that many of you would know about the London Core Review course, which takes place every year in Dhaka, in London. Normally, it's around £500, and it's a 3-day course. There are interactive sessions and sort of how to do sessions, and a lot of faculties come. So this year we have actually decided, next year we have decided to take it to Bangladesh. So in Bangladesh, the London Core Review course will take place in February, between the 18th to 20th of February. It's going to be a massive event. And as you can see, there will be 3 days of lectures and interactive sessions. And on day 5, so day 4 will be a holiday, national holiday, which is 21st of February. On day 5, there will be a wet lab. Now, we are going to launch the registration process very soon, hopefully by tonight. And registration will stop after the first 100 registrations because of limited, seats we have, spaces we have. And only the first 50 applicants will be able to take part in the wet lab course. Now, this is going to be a fantastic core review course. It's heavily subsidized for Bangladeshi participants. The early bird registration is only 5,000 taka for the trainees and medical officers. And anyone above a registrar job, like from assistant professor to junior consultant to professor, the course fee will be around 8,000. And this is the early bird registration. Then the price will go up. And it's also open to international participants. We already had lots of interest from Singapore, Malaysia, India, and other places, and Africa as well, as far as Algeria. So for the international participants, it's around $100. So all of this will take place and finish on the 22nd of February. And we have a PHA Global Summit, which is going to be on 24th and 25th of February. And the presidents of 3 Royal Colleges will be joining that conference. So participants from this course, if they wish to stay back, they can attend our cardiothoracic conference there as well. So I would urge the local as well as the international participants to complete their registration as soon as possible. And we very much look forward to seeing you all in February. So thank you very much. Watch the space. The registration will be open tonight. Thank you. And those who are present here from Heart Foundation and other institutes, if you can kindly cascade this information to your colleagues, that will be great. So
We will
thanks a lot.
circulate this. Yeah, thank you, Shakil. We will circulate this poster to the group so that you can share it to everyone and in your institution as well, so that we
Yeah.
can actually let people know about that. Thank you very much, Shakil. I'm sure this is
Thank
going
you,
to be
Ashwin.
yeah, it's going to be an excellent course as well as a very, very detailed global summit in Bangladesh. The PH is organizing. So thanks again, Rinat. So basically, what we were trying to discuss today is type aortic dissection, though it's very common, and we in this part of the world we are dealing with that day in day out, and some centers like Papworth and Southampton doing maybe more than once a day, but there are some centers which doing not that frequent, but still every centers in the UK, they're very commonly dealing with this problem, which is not very common in Bangladesh perspective, because most likely because of the, I think, the lack of the diagnosis and lack of the no, patient's awareness to ultimately get them to diagnosed and then to send them to appropriate center for management. So the reason for this talk was to give us an idea, basic idea about the type A dissection, that how we manage them, and also to talk about about the setup, how you're going to do, and when you do this operation, what are the things you require to set it up. So in generally speaking, as Ruhina showed on the last slide about a setup, that when the patient comes to theater, it is a combined approach between the anesthetist, perfusionist, and the surgical staff. And it is very important to have these extra few things in the theaters if you're planning to operate. Other than your perfusionist pump, you need to have some form of monitoring of the brain oxygenation, which is most commonly we do with the INVOS or cerebral oxygen spirometry. And secondly, you need at least two, if not three, arterial invasive arterial monitoring line, mainly the left radial, left femoral, and also the right, which will give you an idea about your perfusion strategy during the surgery. And lastly, the different cannulation strategies, which will be something that is not routinely practiced in cardiac surgery, but that's something is needs to be used in aortic dissection. Namely, there was a case. I think I still remember, Sabi, you and I, we were doing it. A case. We started opening each and every vessel. Everything was dissected from subclavian, femoral, central aorta, and ultimately we basically had to cut the aorta, direct cannulation to do the bypass called samurai method. So sometimes you really have to do an extraordinary thing just to initiate the operation, let alone the whole surgery. So what I thought, that rather than just talking about the theory, I'll show you a scan. And Dr. Greco also has done recently a very interesting dissection case. Mainly the diagnostic dilemma was there. And I will show you the scan and just have a look at the scan. Then from the panelists, we will talk about how you're going to assess the approach the surgery, how you're going to cannulate this patient, what surgery you would like to do, and then if anyone have any questions, we'll get there. So let me just see if I can start sharing the images. um, so can you see the scan?
Yes.
Good, perfect. Okay, let me see if I can play it. Good. Okay, so just have to keep on running with this scan. So as you can see, this is a 60-year-old gentleman who presented in the A&E around um, middle of the night with the sudden onset of acute chest pain, radiating from the front to the back, typical history. The only history he has got is hypertension. And when he came to the A&E, his pain sort of settled down by that time. And after morphine, and his blood pressure is sort of stable. So the patient was feeling quite better himself, that now my pain is all settled down. But anyway, the A&E did this CT scan, as you can see. And I hope you can clearly appreciate there is a dissection that is extending from the all the way down to the groin, and that's going all the way up to the abdominal, aorta, aortic root, ascending arch, everything is involved, including the head neck vessels. As you can see, this is the innominate artery, common carotid artery, subclavian artery. The innominate artery is also dissected on this guy. But after that, the dissection, just the proximal part of the innominate artery and the common carotid artery, it's dissection into the arch. If we just change the window to this, you can better appreciate the dissection flap. Sometimes on the scans, you can actually see the primary tear. It's not always, but also I think you can appreciate the significant coronary artery disease on the LAD. And on detailed history, or when I spoke to the patient, he basically mentioned he has got history of some chest pain on exertion, but he actually never been to the doctor for that. So anyway, if this patient comes in, so let's go to our panelists to see what would you do for this patient. How would you, I presume everybody agrees this is a type A dissection that needs surgery, but then what would be your surgical strategy? I will stop sharing the screen now and ask my, let's see who's there. Let's ask Renata, do you want to start?
Yes, so I think it's a quite typical quite typical picture of type A dissection. So as we said, the first things we need to plan is our cannulation strategy. And I mean, there's no doubt this patient is an emergency surgery. And so we need to plan the cannulation strategy. In this case, I would say that probably central cannulation is not one of the easy one, because the true lumen is very compressed. And so it's not very easy to do a Seldinger cannulation in a central cannulation. The dissection extend down, and I think in one on the iliac artery too. So
yes,
so it's so I will keep maybe the femoral cannulation on the side that the iliac is not affected as my plan B, rescue plan. And probably my best strategy would be to try to cannulate the axillary, because I understand that the region of innominate is dissected, but then is well connected with the true lumens, and the main axillary is free from the disease. So probably my first strategy will be axillary if I've got the time to do it. And yeah, I don't know if anybody think differently.
Sabi, do you want to?
Yeah, thank you, Saeed. The first thing to mention is looking at the CT scan. He doesn't have a tamponade, so there's no hemopericardium. If there was a tamponade, if there was hemopericardium, I always start with opening the chest, releasing the tamponade as quickly as you can. And then once you stabilize the hemodynamics, then you will have still time to decide on the best cannulation strategy. I agree with Renata, subclavian/axillary cannulation is still, talking about the right axillary artery, still probably the option we can consider. Having said that, I've done loads of cases from a right axillary cannulation. Recently, I moved in towards central cannulation. So once you open the chest, you assess the head and neck vessels, and even if the right innominate artery is dissected, you can still cannulate the left subclavian and the left common carotid centrally. And it's just less of a hassle. But you know, we've done cases together, Saeed, many cases with right axillary cannulation, and I think that's a good option for this patient. in terms of cannulating. And then probably more than the last 40 dissections, I just stopped clamping the aorta. I know I have to work in the arch. Looking at the CT scan, the patient needs at least a hemi-arch, maybe full arch replacement. In that case, once I establish a safe bypass with constant cerebral oximetry, then I start cooling down, and I just put an LV vent in to avoid any LV distension in case the patient has got some degree of aortic regurgitation. And I just cool down towards 24, 25 degrees. Once we circ arrest, I just open the aorta. So I don't clamp the aorta for two reasons. One is to avoid pressurizing the false lumen and therefore increasing the risk for mark perfusion. The other reason is that I know that I need to do open distal. So what's the point of damaging the intima further with a clamp on? So I always deal with the distal anastomosis first, hemi-arch / arch. And then once that's safely done, I use the graft with a side arm, so-called anti-flow graft. And I switch the bypass into the aortic arch, definitely into the true lumen once I have completed distal anastomosis, clamp the graft, start rewarming, and then you've got plenty of time to deal with the proximal end, whether it's a root, whether it's just anastomosis at the level of the sinotubular junction or a valve replacement. You've got plenty of time to do that while you're rewarming and perfusing into the arch via the side arm graft.
Thank you very much, Sabi. I mean, just one point is that what Sabi mentioned about central cannulations, I recently had to do a dissection where the patient basically arrested. So I had to do a central cannulation directly to the aorta before opening the patient arrested before opening the chest. But then because I know patient needed an arch, I actually managed to cannulate the innominate artery while we were on bypass with the central cannula. And then I put a 8 millimeter graft on the innominate artery, and I did the whole thing with the innominate artery. I did have to do a zone 1 anastomosis just to reimplant the innominate. But then so yeah, this is definitely a strategy. But Renata and we sort of try to go subclavian as like our plan A, and then until unless patient is unstable. I'll ask Dr. Shakil Farid if he wants to just quickly tell me that what strategy you would follow in these sort of cases, the standard one.
Oh, hi, Asif. Thank you so much.
Yeah.
Sorry, I couldn't see the scan very well, but what Zapi and Renata has described, that would be my strategy.
Yeah.
Only thing is, just remind me the CT scan, was it a type 1 dissection?
So yeah, so basically it goes from the root all the way up to the left iliac, left actually femoral artery. But I mean, I've done the case, but the primary tear was actually just mid ascending aorta, but the dissection flap goes.
And how old is the patient?
60-year-old.
So this is a case where I would probably use an AMDS device. I mean, we have used around 30 of these devices. We don't know the long-term results yet, but the early results are pretty good. And I think this is a good case for that because it expands the true lumen very well. And, it's a simple operation. It's quite hemostatic as well, the cuff. So probably this is a case where I would do AMDS if possible. I don't know what's the opinion of others.
Thank you very much. So those people who don't know, AMDS is a stented device that used in the dissection. It's a stent which is a fenestrated stent. Basically, they have got stent which is not covered, uncovered stent, through which blood can go into the head neck vessel. But then usually it helps to expand the true lumen and helps to thrombose the false lumen. There's a lot of technical factors involved in this one. You need to know about the arch anatomy, and you need to know actually whether the patient has got any tear on the arch or not, which in some cases are not indicated. But I think Pepper is one of the centers have done maximum of this, so they have got a huge experience.
Yeah.
And Dr. Farid actually has got a quite experience on this. So so that's really important. Another
So for the
approaches that can be
AMDS,
done.
Asif, the important thing is, as you have said, that young patients who otherwise have connective tissue disorder with a slightly dilated arch or descending, where you are not going to do anything about now, you wouldn't probably use the AMDS device there. Or if it's a type 2 dissection, so just confined to the ascending aorta, or if the tear, as you have said, is in the arch or proximal descending aorta, you wouldn't use the AMDS device. But other options, I'll just use the AMDS device because I think it's not bad. It's good and it's quite simple to use. You just need to know how to deploy it. One of the things is, if you're using an AMDS device and you do a central cannulation, it can be a little bit fiddly putting the antegrade cerebral perfusion cannula through the head neck vessels. So that is the only tricky bit, because we do in TAPFORD 100% times we do subclavian or innominate. We don't face that problem, but those who do central cannulation, it may a little bit fiddly to put that through the stent.
Yeah, thank you very. Yeah, no. So basically, I'll just quickly tell you. So this guy, I did a routine operation. So I did subclavian cannulation. I did an open distal anastomosis. As Abby said, I don't cross clamp the aorta anymore. Not do the surgery in cross clamp, but I do sometimes cross clamp to do the proximal bit if I know there are some more complex proximal bit I need to do. But then do an open distal anastomosis, and I'll just share you the spread. And then that's what it looked like. It is 3 months down the line now.
Said, can I just add one thing? So if you clamp the aorta, you need to be you need to wait few good minutes before you open the aorta, because you need to be sure that your clamp is not changing the dynamic of the true false lumen and that you are perfuse all the organ you want to perfuse. And if you go on it up, just take the clamp out and just wait and do it
wait
up.
for exactly.
So
this is a very important point, because
it's a very I think I've seen people really struggle.
The moment you clamp the aorta, you actually commit, and you have to wait for the malperfusion syndrome, as Sabi was saying. And if that happens, then the thing to do is just to take the clamp off and just wait for the temperature to cool down to 24 or 26 till you can go on antegrade cerebral circulation and circulatory rest. So as you can see, the false lumen is more or less thrombosed now, and the contrast is going quite less, but there is still false lumen in the arch and the descending thoracic aorta. So this is a patient who's going to have follow-up with us for the rest of his life with yearly scan. But post-operatively he did. And also the other thing I did, because of his history and the coronary disease, I grafted his LAD on a vein graft. It was very calcified. So that was sort of like a preventive strategy rather than any obvious indication, because we didn't have any angiogram. So this is like one of the basic case that we find most of the time with the dissection, and we just have to make our plan for these surgical strategies. Now there is another one I'm going to share, but before with that, I would just like to ask from my Bangladeshi colleagues, Dr. Prashanto, if you want to add anything or give his opinion about these scans we're looking at.
Thank you for asking me my opinion. Congratulations, PHA. In the month of September, you arranged this aortic dissection management strategy. Congratulations, Dr. Shakil, to arrange 19th September a huge gathering in Pepward. We actually used to celebrate this day here in Bangladesh also, because we need some more motivation for our local, the peripheral centers to diagnose aortic dissection case earlier. Then we'll get much more younger patients, especially for the connective tissue disorders for that. For this excellent case from Dr. Asif, I like to mention that yes, right axillary artery will be the good choice if patient is stable enough. if not there is any tamponade or something like that. And if there is actually other than involvement of the arch is there, then why we will go for open hemi-arch, as well as we can go for actually frozen elephant trunk with total arch replacement along with
Yeah.
stabilization of the root if there is. This is my
Yes.
comment.
Yes, yes, absolutely. So depending on the extent of the primary tear, as
Yeah,
Ruhina was
primary
mentioning,
tear,
the surgical strategy depends on the primary tear. We need to exclude that. So if the primary tear goes up to the arch, we'll have to exclude that primary tear somehow. And for that, we might have to do a total arch replacement, either by a frozen elephant trunk or by a conventional total arch replacement. So it depends on the extent of the tear. There is a very interesting question has been put on the chat that in Bangladesh scenario, say for a 59-year male patient with acute chest pain and then ECG showing inferior MI. And the question is, how can you differentiate it from an aortic dissection involving the right coronary artery when the CT angiogram is not available? It's actually quite common situation in Bangladesh perspective that CT is not available everywhere. So is there any investigation that can help? And is there any echocardiographic characteristics to differentiate? So I will ask my panelists to answer that, and then hopefully I'll get there. Is Arman Bhai here as well?
Yeah, I'm
Dr.
here.
Arman. Yeah. Do you want to take it? Do you want to answer this question?
CT scan is not available. I think
So
if CT scan is not available, initially we can take help from the echo. Both transthoracic and transesophageal echo can readily help us out. I think in this situation.
yeah, no,
If CT
absolutely
scan
right.
is not available.
Yeah. So I mean, we have got our
I like
radiology
to add
panel.
one thing. If I
Yes, please.
suspect this is to exclude acute dissection, we will go for some biochemical test like D-dimer and also along with chest X-ray and echo. I like to add
Yeah.
D-dimer.
Yes. Thank you very much, Prashantara. Dr. Sadia.
I'm of course a cross-sectional imager, so CT and cardiac MRI, but in Bangladeshi perspective, I would say first thing we do always is a chest X-ray. So there are chest X-ray features which can help, but also it's not very accurate. So sensitivity, specificity is lower. But as the other panelists are mentioning, echo is very good. Transthoracic echo can look at ascending aortic or aortic root, but descending aorta assessment is difficult. But transesophageal echo, if there is expertise in the periphery, it has got a very high sensitivity and specificity, I think over 98%, which is close to CT. So although you cannot see the whole extent of involvement or the branch artery involvement in end organ perfusion, all this information you will not get, but at least you will have an idea what is causing the question, basically STEMI or NSTEMI for this patient. So, and also the other information you get from echo, which is extremely valuable, which you cannot get from CT most of the time, is valve dysfunction. So whether you need to replace the valve or anything related to basically pericardium. So CT, of course, is good, but if there is pericardial hemopericardium, you can see on echo. So that can give another suggestion of aortic dissection. So I think chest X-ray and echo, particularly TEE, will be excellent in diagnosing aortic dissection, particularly ascending aorta type A.
Thank you very much. And this is very important. Unfortunately, TE may not be available. Just to clarify one point, when you've got a patient who is right coronary artery is involved and you suspected either this is either MI or is it a dissection, so the dissection has to be in the ascending aorta or it has to be a type A to involve the right coronary artery. And the good thing is that even if you do a transthoracic echocardiogram and if it is a good quality window, depending on the window, you could see a flap in the parasternal long axis into the ascending aorta if there is an actually. And also what you can also see, according to the flap, there will be either moderate to severe AR because the dissection flap will go all the way into the sinus. It will invariably cause severe AR. That will also be a telltale sign that the right coronary artery is involving because of a dissection. So to differentiate, the echocardiographer who does this echo, they need to have that in the back of their mind, because as you know that if you don't look for it, it's very difficult to find out. So that's would be one of the way to find out. But as we know, transesophageal echo has got very high sensitivity in diagnosis dissection, but that is also another stressful thing to do in a complex situation like this, because you need some sort of sedation to do a transesophageal echo, and dissection patient may not be stable enough to have that. Uh, but this is one of the difficulties in Bangladesh. We don't have the logistic to do CT all the places. Yeah.
I think also
Sorry,
medical history and examination of the patients are very important, because there may be other sign. So you can have differential pressure between the left and right arm, or between the radial and the femoral. And also take a good history of the type of the pain and the presentation, because often the presentation is different from, it's not the conventional way they presented. Sometimes there can be other symptoms like neurological symptoms, peripheral symptoms, abdominal pain, all these things that make you think more towards a dissection rather than an acute coronary syndrome. So let's don't forget the basis, that is take a good history, examine the patient, because often there are other clues there that they can help us.
Thank you very much,
I want to add a
Renata.
point.
Absolutely.
Asif.
Yeah.
So where there
Yes,
are facilities
please, yeah.
to do cardiac, CT angiogram, I would like to emphasize, and although this is a program on acute aortic dissection, but the spectrum is intramural hematoma. So please specify or have a look if you're looking at the images, particularly in Bangladesh, a lot of physicians or surgeons look at the images themselves first before going to the radiologist or getting the read. A non-contrast CT is very important to look for intramural hematoma, which may be blurred when you give contrast. So that's one of the things you need to emphasize on when you request a CT. And also ECG gating. I probably in every meeting I attend, I emphasize on that. If you have the imaging facility, and if you have the ECG gating facility, do the scan using ECG gating, because I have come across both in United Kingdom and in USA having patients who had median sternotomy because decision was made from non-gated imaging that there is aortic dissection, which were actually motion artifact, and after median sternotomy, there was nothing at all. So to avoid that confusion or complication, we don't want that for any patient. So please emphasize on ECG gating. And if you look at a scan yourself as a physician or surgeon, always ask the question, is it ECG gated or non-gated? Because motion artifact can mimic aortic dissection. So that's what I wanted to mention. The other point is, if you don't have, for follow-up, if you don't want to give contrast, then you can do non-contrast MRA. There are very quick sequences, which will not be as expensive as post-contrast ones, because you wouldn't give gadolinium. So for follow-up, you can use both CT or MRI according to what you are looking at.
Yeah. Thank you very much, Dr. Sadia, because that's basically what our protocol. We do MR for our patient for follow-up. The important point to highlight here is that the gated CT is very important for the aortic root of the anatomy, and especially there I have recently where a case report patient diagnosed with CT scan, but gated CT ruled out. Patient didn't have a surgery at the end, and it is important. But so also there is IMH and vasculitis, which can be differential diagnosis, and that can also sometimes be cause for a unnecessary sternotomy. There is a question about if the patient presented with MI, and then what would be the thrombolysis decision. Now, this is just want to highlight is that we in England as well, Sabi would even agree, even in Southampton, Dr. Shakul would agree, in Papworth, we all see patients coming with loading dose with aspirin, ticagrelor or aspirin, clopidogrel, because they were diagnosed suspected MI, or they are given loading dose because they suspected PE, and they're coming in for us for surgery. So even if their diagnosis is done, then we still operate on them, even they have been loaded with what you call that, loaded with the antiplatelet medications. But if you have got any doubt, and that's why the dissection awareness or the teaching we were doing in UK at the moment, because this is been diagnosed by the ED or the A&E doctors. So if they are the first person who is getting in contact with the patient. So if you have that doubt, and then you just for that particular patient or one patient, as Renata mentioned about the history, examination, echocardiogram, any sign that give you a suspicion, and if you have that worry that the dissection is a differential diagnosis, then definitely you will be able to diagnose this case and organize every now and then at least one CT scan. So that's with for particularly this case. If anyone else has got any question or comments before I go to our next one. Okay, good. So Renata had an interesting case. Renata, do you want to just quickly talk through while I get the images up, or do you want me to?
So this patient was an 80 years old gentleman who presented who collapsed at home and then was transferred to one of our district hospital. And during the stay at the district hospital, he suffered 2 further cardiac arrest events. And an initial CT scan was performed, but it didn't, as you could see, probably the second one is a bit more clear, but it wasn't the clear appearance of a type A dissection. So actually the patient even went for a coronary angiogram, and then during this period he suffered another cardiac arrest. So then a gated CT was performed. And now Said probably is going to share with you. And you can see it's not the...
I'll show the gated CT, yeah.
I think it's the best one. So as you could see now, it's not the classical appearance of the type A dissection. So there was a bit of talking within the group and how to interpret this CT. I probably wouldn't say anything else till we see the images. And then...
Can you see the scan?
It's not moving, but we
probably
can... It's coming, yeah.
Yes, this one is probably the gated, yeah. Is it moving now?
Yes.
Okay. You just up.
So the patient also receive resuscitation with external compression. You can see that there's a left hemothorax. And so there's definitely this massive aneurysm of the ascending aorta. And then there's this strange appearance in the proximal ascending root. And there's a pericardial collection there. And I think it's probably just go back around the root is where it's a bit more. So just above the root, so just there.
Asif, sorry to interrupt. If you don't mind windowing to bony window, probably it will be easier to see the flap.
Yeah. So I'll start running it again.
So you can see the difficulty here. There is no true and false lumen, a clear one. So like usually appear in a type A dissection.
Yeah.
There's a hematoma around the aorta and also around the left main stem and the left coronary. And this image is just there, just at the level of the STJ, that is a bit suspicious.
So Renata, just if anyone wants to comment about this scan. Dr. Sadia?
Can I go first?
Yes, please. Yeah.
So yes, this can be challenging if ungated CT is performed, but this is a gated one, and I think for probably trainee radiologists, it may be a bit difficult if you don't look at a lot of dissection scans, but it is pretty obvious there's limited intimal flap, we call it. There's limited intimal tear. It's not full flap dissection, as you have said already. And the pericardial fluid, radiologist friendly is Huntsville unit. That should be for everyone. So if you put your ROI in the pericardial fluid, and if you say the Huntsville unit is more than 30, 40, then it is blood. So if it is blood, then you have to have very high suspicion with this massive aorta. So there's aortic aneurysm, there's a limited intimal flap, and hemopericardium. Probably the pleural effusion, if you put Huntsville unit there, it may be over 40, then there's hemothorax, maybe bilateral. So all these together put the diagnosis of acute aortic syndrome. So that's my comment is going to be. But I can see this may be challenging in cases where you don't see many dissections like this, where limited flap is present.
Yes, basically, Renata will go through, but this caused a lot of problem because we are talking about an octogenarian with 3 episodes of cardiac arrest. And until unless we really know what we are dealing with, should we take the patient to theater or not? So there has been multiple discussion on our complex MDTs. Renata, do you want me to show the images, or do you want to tell us anything else?
No. Yes, I mean, another interesting thing is just talking which will be the cannulation strategy, and actually this was if you look actually at the distal ascending aorta, it all looks come back to normal. So it actually was probably
it does.
I don't know, maybe my only dissection probably done with the clamp on. So you know that there's nothing going on in the heart, it's all in there, and so you can even think in this case was definitely a central cannulation, and actually the patient had another cardiac arrest during induction. So we have to resuscitate him before starting the operation. So we definitely went for the central cannulation. So I think the picture will be very interesting to show because we took some pictures in theater. So so the initial report, just to say, was that there was a folding in the aorta. So it's something that really doesn't exist. And so intraoperatively, we found a hemopericardium. We found blood in the left side of the chest, and then what we found was a large aneurysm with what was fundamentally a cover rupture of the posterior wall of the aorta. And so if you show the photo, maybe we can. So just at the level of so just at the level of the STJ. So this is so we are looking from the head of the patient towards the toe. The sucker is inside the root, and you can see just above the STJ there are these 2 areas where the aorta was completely ruptured, and because it was a posterior rupture, it was tamponed by the tissue behind. And that's why he appear in a different way on a CT and not our usual true lumen and false lumen finding. And the patient is doing very well. He's at home. He's recovering from surgery. Obviously, it was a bit of a slow recovery in an 80-year-old gentleman, but he's doing very well. And this is another, maybe open another also thinking as what we do with octogenaries that present with dissection. That is always a kind of difficult decision, and I think everything depends on the quality of life and how good is the patient before the dissection, really.
Sabi.
Thank you, Said. We looked at, just linking to what Renata just finished with, we looked at our own dissection data, particularly in octogenarians, and their survival rate is actually not too bad, but the stroke rate is unusually high, is about 23-24%. So octogenarians, despite of all the effort, whether you do open or closed distal, for some reason, mainly due to their frailty and comorbidity, they have high risk for perioperative stroke. I agree with the strategy here. I mean, for me, from the gated, from the gated CT scan, it was obvious that the patient had a pre-existing ascending aortic aneurysm, which obviously had a limited tear, probably a contained rupture, which we know is now a contained rupture. And he had multiple cardiac arrest due to the pericardial tamponade. So it's a form of acute aortic syndrome. I agree with the comment then that in octogenarians, particularly when the aortic arch looks almost normal size and good quality, central cannulation, even direct aortic arch cannulation can be considered. And these are the rare cases where I would also probably prefer to do the distal anastomosis with a clamp on.
Thank you very much, Savi. That's really helpful. And this was really tricky case because of the octogenarian age and of the diagnostic dilemma. I mean, we know patient had bled, he's got pericardial collection, but the dissection was not a clear-cut 2 false lumen, and we're talking about whether he would be fit enough to go for surgery. But Renata, really nicely done. It's one of the few heroic cases he has done so far, and the patient did really well. So these are the two cases I thought we'll just go through rather than talking about um, one more scenario. I've got a case as well. I can show you the scan, but the scan basically doesn't show anything else other than a type aortic dissection. But the history is very interesting. This is a patient who's only 55 and presented after an echocardiogram from the district hospital. They did an echocardiogram because patient presented with acute sign of heart failure, pulmonary edema, and fluid overload up to her navel area. Basically, she had anasarca with heart failure features, and the echocardiogram shows she's got severe aortic regurgitations, but the patient's BMI is about 45, so windows were not very good, so they couldn't see about a flap. This patient admitted in the hospital 3 weeks before this admissions with acute onset of chest pain. They did a CTPA and could not elicit any finding of diagnosis of dissection that time because of lack of contrast, I presume. The patient went home and she came back with acute severe AR with pulmonary edema, heart failure. And this time the echo showed there is a dissection flap. So they did a CT scan and clearly there is a acute type A dissection for this lady. Now the question is that she's already 3 weeks down the line. When she came in, she was in proper heart failure with bilateral pleural effusions up to mid area. She is in proper heart failure, pulmonary edema, was requiring oxygen. Now, in this group of patients, would you want to take the patient to theater then and there? Or would you wait at least 1 or 2 days for them to manage with IV diuresis to get their lungs a bit dry before putting them on circulatory arrest? And I will tell you what I did for this case, but I just wanting in this sort of dissection situation when you know this patient has got dissection, but they are already 3 weeks down the line from their diagnosis. So they are not acute anymore. They fall into the subacute category. So what would you do that? Sabi, do you want to start, please?
Thank you, Said. Yes, so like you said, she has already survived the most critical few days, in fact, 3 weeks. So it's very unlikely that her aorta suddenly will rupture. And I think on the balance, she sounds like she would benefit from a couple of days of offloading and then therefore giving her a better chance going through the surgery. So I personally would have put her on IV furosemide, diuresis her aggressively, and plan her surgery as a sort of urgent within a following 48, 72 hours, depending on how she's responding to the diuresis and offloading.
Yeah, that's really helpful. Renata, I want to ask because we were together on these sort of cases anyway. But I was just wondering if we have got anyone else around here. So basically, I exactly did what Sabi said. I waited for, I waited for 24 hours because the moment the images was transferred, we have already given them the advice and they started the IV diuresis. And by the time she came in, she's already started to diurese well, gave her 24-hour time, and she really recovered well from there. And the tear was completely on the ascending aorta, which goes all the way up to the non-coronary sinus. So the non-coronary sinus, the cusp was completely prolapsing in the root. That's why she had this torrential AR. All I had to do is to replace her ascending aorta and resuspend the aortic valve, and didn't even have to do the root, and she did really well afterwards. So, sometimes the diagnosis can be coming a bit late, and then the decision making is very important when you're going to operate on this group of patients. So, no, thank you very much, Sabi.
I want to add
So
a
this is,
comment there.
yes,
if
please.
that's all right. Sorry, I'm talking too much probably. The diagnostic dilemma. So initially she had a CTPA for a pulmonary embolism suspicion, but pain was probably from dissection. And then it was diagnosed a bit late. So for the centers in Bangladesh and England as well, in my experience after coming here, I thought that in England, I thought double rule out or triple rule out CTs are quite complicated, but actually it's not. So it's quite simple to do. So if you have got this diagnostic confusion of what's going on, so you can do even triple rule out very easily. So if you ask for a coronary CT angiogram and add some more contrast and extend the field of view, you can get every information you need from the same scan. So you can assess your coronaries, you can assess your aorta, you can assess your pulmonary tree. So that may be useful in Bangladeshi perspective because one scan can sort out a lot of things, even can prevent the patient to go to cath lab for coronary angiogram. So that's what I wanted to mention.
Thank you very much. Thank you very much, Dr. Sadia. It's really helpful comment on that. We've got Dr. Jahangir Kovisar as well with us now. So thank you very much for joining here. We were sort of talking about some scans about dissection. So I think it's nearly 6:30. It's about 11:30 in Bangladesh. So I will hopefully try to. Sorry, Sabi. Yeah.
Sorry, Said. I'm not sure if you have time. I've got an interesting question in my mind.
Yes, please.
If a couple of minutes. I would be personally interested to see what the different centers and colleagues from different centers think about intramural hematoma and whether they treat intramural hematoma as any different to dissection on a CT scan. And also the last question regarding that is, has anyone actually seen true intramural hematomas? Because in my experience, every time when the CT scan report says intramural hematoma, we take the patient to theatre, we open the aorta, and we find exactly the same dissection. So true intramural hematomas are very rare conditions. I haven't seen one, but I wonder whether has anyone seen intramural hematomas, and also whether you treat it different to a type A dissection. I know it's a form of acute aortic syndrome, but I'm still aware that some centers are a little bit more sort of relaxed on treating intramural hematomas in terms of not taking them straight to theatre, waiting till the following morning, and then have a delayed operation.
Thank you very much, Sabi. It's a very interesting question and important. I can tell you what we do in our center, but before that, I just have to see if Dr. Shakil Farid is still available. Do you want to any comment?
Hi, yes,
Yeah.
Thank you. Sorry, it's a bit noisy. Let me go to the other room. Yeah. So, I mean, true intramural hematoma, as Savi has said, it's actually true that it's very rare because it's a spectrum we are talking about. You know, the patient starts with a PAU, develops intramural, and then gets a dissection. And by the time the patient comes to us, it's already a dissection, not an intramural hematoma anymore. So I have seen 2 or 3 of this. You know, I mean, we do around 50, 54 dissections a year. So we do see 2, 3 of them. With regards to the timing of the surgery, if it's in the ascending aorta and if the patient is having pain, I usually don't wait. I just use it as a, you know, I just take it as if the patient has dissected. And in those situations, most of the time, you would see a dissection, as Sabi has said. Um, the intramural hematomas, which have presented few days back in their other hospital, in the DGHs, and then there has been slight delay in diagnosis, and then they come over to our hospital. If they're stable, pain-free, I would probably wait. I wouldn't start it in the middle of the night. If it's evening time, I would start. But if it's like 2, 3 o'clock in the morning, I would probably start wait till the morning, because the patient has already waited for 2, 3 days and they're pain-free. So risks of that turning into a dissection or some problem is quite low. So I think you just need to manage this case on case-to-case basis. But strictly speaking, if you look at the guidelines, it's a class 1 indication. So, you know, you should operate on them. And there are some high-risk features of intramural hematoma. If the, thickness is more than, 10 millimeter, if the aorta is dilated in addition to the intramural hematoma, and as I've said, if there's ongoing pain or pericardial effusion, you just deal them as if you are doing a type A dissection.
Thank you very much, Dr. Shakil, for it, because Sabi, that's what exactly we do in our center as well. Renata, I will ask her next, but because we basically follow these 4 points: the intramural thickness, the hematoma, that one, more than 10 millimeter, pericardial effusions, and the size of the aorta, and patient's pain. Then we just go ahead. If not, then we will still go ahead, but then basically probably in a broad daylight rather than in the middle of the night. Renata, any comments?
Just to say, sometimes these cases are actually the most difficult one, because between the layers, what you find is just mushy thrombus, and all the tissue are very mushy. So rather than have a nice layers to put together, it's very difficult, because they are really, really, the tissue are horrible in this case. So in terms of timing, yes, I completely agree. But the problem is sometimes you need to be more aggressive than you thought you had to be, because sometimes you need to go down into the root, because you can't really reconstruct the layers the way you do in a normal dissection.
Exactly, because the tissues are more friable. Because the in between the flap, basically there is all clot, and the tissue is so mushy that stitching in the STJ can be very tricky. And most of the cases end up doing a root replacement just because we can't reinforce the STJ. There was another question on the chat, that what would you do if a patient present with dissection but they are on rivaroxaban or DOAC? And this is something is not uncommon, and even you see patients with a mechanical valve redo coming with warfarin. So as Renat has already answered, there are some reversal agent for DOAC what we can use at the moment. But unfortunately, because the patients are DOAC, you cannot not do a dissection. You have to go ahead and get the surgery done and hope and pray for the best that the patient will stop bleeding. Worst case scenario, pack the chest, wait for 48 hours, and then close. So that's, I'll just quickly go through my panelists, Professor Jahangir Kobir sir. So thank you very much for joining. I know you have an extremely busy schedule, but really thank you very much for joining today. Do you have any comments for our juniors and doctors over here?
First of all, I apologize. I was stuck in the theater. I just joined now. I'm love to hear you. I was just starting hearing you. I mean, I really apologize. I was in a very bad soup in the theater. All of us.
Oh.
I don't know. United Group probably could not. I don't know how many of you have joined. And anyway, I'll just listen to you guys. No comment.
No. Thank you very much for joining, sir. I know. I mean, it's a difficult days for you, but what we will do. So we have got the link as well, and if you would be kind enough, we can send it to there. You can actually have a look at it again. We had a couple of interesting scan and pictures we showed, and will probably intrigue some interest. I'll go to next to Dr. Prashanto Kumachanda. Dr. Prashanto, do you have any comments? Sorry, Dr. Prashanto, you're still mute.
Thank you.
Yeah.
Thank you, PHA, for arranging such a good, actually, topic, which is really time demanded in Bangladesh, as we are actually running with shortage of our delayed diagnosis. And for that also, we have some more morbidity for our regular cases. And for other than syndromic cases also, we have lack of our diagnosis. So we have to look for those syndromic counseling and genetic counseling and testing for the families also with these things. And we have actually lot to do with the aortic cases, I hope. And this type of seminar and symposium will help for Bangladesh to develop their aortic surgical program exclusively in different centers. And wish in next near future, we will elaborate it with our radiological findings from the aortic radiologist. This is one of my appeal. For we will include our radiologist as well.
Yeah. No, that's really, thank you very much, Dr. Prashanta. Dr. Shakil, do you want to sort of add your comments?
Yeah, no, thank you. First of all, I would like to thank all the panelists and also Jahangir Kobi sir and Prashantoda for joining despite their busy schedule. And of course, Sadia, she's a new addition to the team and she has been doing a fantastic job with our radiology faculty. For Prashantoda and Dr. Jahangir Kobi sir, I just wanted to re-emphasize that we are going to do the London Core Review course in February, and we'll very much expect your active participation in that. We are planning to run some wet labs, which will include valve-sparing aortic root replacement, surgery for aortic dissection, then Bentall procedure, those kind of things. I think it will be very, very good for the trainees. So I would be grateful if you kindly encourage your trainees to register for the London Core Review course. And we'll be having world authorities like Jebrin Al-Khoury, Professor David Taggart, and lots of other international faculty members there, including people like John Doty, Lee, then Aziz Momin. Yeah, so it's going to be a fantastic conference. And as you can see, the whole day on 22nd will be dedicated to wet labs, and it will be organized by CSSB. So there will be active involvement from the societies in Bangladesh. So I will urge you to encourage your trainees as well as the other MS trainees to register for that. Thank you. And thank you once again for your time today.
Thank you very much, Shakil bhai. And I would just encourage all our trainees from Bangladesh, please do join. This is going to be an excellent
No,
course.
well said. I think well said, Shakil and Asif. I think we had already discussed about this training in February. We are looking forward, very eager. I think what Prasant was saying, that actually radiology has to be incorporated. Diagnosis is very important. It is like once you can't diagnose such a cases of chest pain with dissection, you hardly can manage in a scenario like in our scenario. So it has to be a team effort, number one. Number two, some theoretical background understanding is also needed. And finally, the surgical techniques has to be adopted. I think this area, as I was discussing with Asif earlier, I mean, this aortic surgery and aortic dissection and all these things, we are little behind, quite behind as compared to the many other countries. We were initially, like India, Bangladesh was similar in this particular type of surgeries. Where I was trained was not also, we didn't see such dissection cases. So looking forward, I mean, it would be a great help for the surgeons of Bangladesh. And I believe interaction in February will be a great, and we will participate with all effort, definitely.
Thank you very much, sir. It's really, really.
Thank you very much.
Sabi, do you want to add any comments?
Very, very quickly, Said, thank you very much for the invitation, for the opportunity to participate in the discussion. Obviously, we have discussed interesting cases and different surgical strategies. One closing comment is probably from me that dissection awareness can save lives. We are not the ones who will meet these patients first in the A&E department. And then I can only imagine that colleagues at the A&E department, they will see hundreds of patients with chest pain, whether it's cardiac or non-cardiac, before they actually see someone with type A dissection. So I think it is important for us to organize teaching or training sessions where we actually go and meet these colleagues working in an ED department to make sure they are aware and they, in their sort of thinking process, anyone who presents with sharp, sudden chest pain or back pain should be considered as a potential case for dissection. Thank you. Thank you very much.
Thank you very much, Sabi. It's so important for us to have, because as you clearly said, that we are going to be seeing the patient last. The first person will be the NE and the medics where the patient is going, or the cardiologist with the chest pain. Renata, do you have any comments?
Now, just say thanks for the invitation and congratulations for organizing this very nice web lab. I think we are all enjoy very much. I hope the trainee enjoy it too. And
yeah, thank you very much, Renata. If you don't mind, we'll keep you as a regular panelist from now on. So,
Asif,
yes.
I'm not entirely sure whether people know that Renata has worked with one of the biggest aortic group in the world, in Italy. Pacini and all those people, she worked with that team, and it was very useful to have her when I started the FET program in Oxford. She was my wing lady. I would say so. It's a great pleasure to have Zabi and Renata here. Yeah.
Thank you.
Absolutely.
Thanks.
And I was just telling at the beginning that she's basically my mate in the hospital at the moment on all complex aortic cases. Usually me and Renata together doing all the arch or the major complex root, and all valve sparing we have done so far, all doing together, even in bicuspid valve. So yeah, we're doing quite good. Last, Dr. Sadia, please, any comments?
My another star colleague, former colleague.
We are a very close family. Thank you so much for giving me the opportunity to join this session. It was excellent. The presentation from Ruhina Alam was really, the summary was, I still think like this was a wonderful job she did, putting a huge topic in a few slides. Excellent moderation, Asif. You're always wonderful. I will just say the same thing like other panelists, like the awareness of aortic dissection needs to be improved everywhere, in ED, in UK or in Bangladesh. And diagnostic tools are available, but how to use it and when to use it, and how to interpret the images, probably training sessions in ED or among the cardiologists, surgeons, and radiologists also important. So probably in future we can organize some sessions on interpretation skill. I've shared a couple of wonderful papers from RSNA, which are free. Usually you have to pay $75, but these are 2 free articles. You can have a look at your leisure, but there are a lot of important findings mentioned there, which you can watch out for. So thank you again for inviting me on this session.
Thank you very much, Sadia. It's been a pleasure to have all the time, and especially you joining in all our cardiac sessions and give your expertise on the radiological input. And I would like to just end that we are doing this awareness program even in UK in different hospitals as well as centrally. And I would think I'll request to Professor Jahangir Kovi, sir, I think we should do something in Bangladesh in different centers. We can do as a webinar or a face-to-face session about the dissection awareness, basically, so that we can pass this message to the root level who are going to see these patients, and that have the idea that yes, this patient may need a CT scan. As Sabi is saying, that just diagnosing one, there's a chance that that patient will be able to survive. So even a one patient's life, if we can achieve by surviving with this awareness, then I think it is going to be a very important thing. And with this, I thank you everyone to join this session, and I wish everybody good night. Shakil Bhai, sorry.
No, thank you, thank you,
Oh, okay.
everyone.
All
It's
right.
lovely to
No, no.
have you guys here. So, I mean, I think there was one Aortic Awareness Day in Bangladesh, which was organized by Sajjad many years
Yeah.
back, and
Yes.
there are lots of dissection patients in Bangladesh. Two of my family members, not first degree relative, died of dissection. One was Jahangir Kubis sir's patient. She was very frail, and she was 84. We all decided not to operate on her, which was the right thing. The first Lois Dietz patient I saw in UK was a Bangladeshi patient, and I have operated on quite a few Bangladeshi patients who migrated from Bangladesh to UK. So it does exist in Bangladesh, and we just need to be really aware about this. And as Sabi has said, cardiac surgeons are very peripheral in the whole thing. The diagnosis needs to happen in the A&E, in the cardiology ward, on the medical ward. Otherwise, you will never be able to help these patients. So thank you all.
Thank you very much, everyone. And wish you all the best. And hopefully we'll see you in our next session. Thank you very much.
Thank you.
Goodbye.
Thank you.
Thank you. Thanks, everybody.
Bye. Bye.
Thank you, Shakil. Thank you. Assalamu alaikum.